Hello, everybody. And first of all, I just wanted to say how great it's been to be working on this project. And I just want to compliment the government of Kenya for the foresight that they've had in really putting together outstanding data. We, as a team, we've been marveling at how rich the data is in Kenya and how it's been used to understand and monitor the epidemic. There's so few countries that we've worked in where this kind of analysis can be done. So it's really a pleasure. In this analysis, what we've been trying to focus on is a couple of key questions. And one is to look at ways of looking at geographies. And I know this is done in every country. Kenya's done it a few times. So just to refocus attention on, as Kenya has moved a lot of their programming down to the county level, trying to understand in sharper detail geographic prioritization, and then also looking at populations and thinking a little bit about how different counties are different in terms of what the priorities ought to be for their prevention strategies. And then we also incorporated a program assessment, starting to look at where are there gaps in prevention program. And this is, I would say, the understanding of gaps in prevention or areas for opportunities for improving reach and coverage is still something that that's fairly early, but I think it's something that is a really important area for focus going forward. Next slide, please. So 3 components for the epidemic appraisal. One, we're going to look at just basic HIV incidence and prevalence at the county level to try to understand how to prioritize. Then we'll look at epidemic typology just to try to categorize counties based on their transmission dynamics. And then I'll spend the last part of the presentation looking at program gaps. Next slide, please. So I think the first thing is really clear in Kenya that there are a relatively small proportion of counties that are contributing a relatively large percentage of new infections. So these are estimated new infections by county based at 2020. And you can see that there's about 9 counties that account for about 64% of all new infections. They're at the left side of the graph. And you can see the smooth curved bar is showing the cumulative number, and the lighter blue bar is showing, or line is showing the actual number by county. And then once you get to the top 17 counties in terms of number of new infections, you've reached about 82% of all new infections. And so really important to understand the basic concentration of infections within the country as a way of thinking about where the impact will be from prevention. Next slide, please. Another way of thinking about it is looking at the incidence prevalence ratio. So this is a metric that allows us to understand the incidence in relation to how advanced the epidemic is already. And that's important because it gives you a sense of, obviously, the higher your prevalence, the higher the incidence. So the incidence prevalence ratio gives you a sense of the amount of movement you can have in terms of prevention by reducing incidence. And here, once again, what we find is that there's quite a bit of variability in the incidence prevalence ratio across the counties. So some counties have much higher incidence prevalence ratio than others. But also, interestingly, you can see that some counties with high case numbers have still a very high incidence prevalence ratio, whereas other counties that have high numbers have a much lower IPR. And so this is another metric that helps us look at where's the room for improvement in terms of impact. And so I think it's an interesting and important metric to be understanding on a county by county basis. Next slide, please. Another way of framing this. So in this case, what we've tried to look at is we've tried to look at the incidence and the prevalence, and then looking at that in relation to the annual number of new infections. So the higher these bubbles are, the higher the incidence. The further to the right, the higher the prevalence. And so you can see there's a strong relationship between incidence and prevalence, not surprisingly. You have a cluster of counties on the upper right part of the graph that have both high incidence and high prevalence. But you also have some counties like Nairobi and Mombasa that have pretty high number of new infections, even though their incidence and prevalence isn't so high. So there's a mix in terms of contribution to the overall epidemic. You have a mix of those that have already high incidence and prevalence, and then some that aren't as high in terms of incidence and prevalence, but will contribute, that are contributing quite a bit to the number of new infections. Next slide, please. And this just, when we were looking at the roadmap in Kenya with a plan for 75% reduction of new infections overall in the country, which is the sort of overall goal. What we found is that if you look at just the IPR, what you can see is that a 20% reduction in IPR, incidence prevalence ratio, overall would result in a 75% reduction in new infections. And this slide just shows what would be the number of new infections averted in each of the counties if their IPR was reduced by 20%. So you keep the same bar in terms of prevention, in terms using the IPR, but then it allows you to sort of see where you'll have the biggest impact on the overall reduction in the country. So Nairobi, Kisumu, Homa Bay, Siaya, obviously you'll get your biggest impact there. But this gives you sort of a numerical or quantitative assessment of the impact of a 20% reduction in IPR by county, sorry. Next slide, please. Next, I'm going to go to looking at the epidemic typology or the transmission dynamics. This is something that in HIV prevention, we've been trying to do this for more than 2 decades, trying to come up with good ways of categorizing epidemics. We've come to fairly straightforward rules of thumb, which have been supported by some modeling analyses in a lot of different contexts. And we've just applied those to the counties in Kenya. Next slide, please. So this is, we published a paper several years ago to look at the different typologies of epidemics, and we used the general framework that's been used for over 2 decades, the idea of a concentrated epidemic where the focus is on priority populations or key populations because that's where most of the transmission is. We have generalizing epidemics where you do have key populations, but a lot of the transmissions happening beyond key populations. So there should be more of a focus on high-risk general populations. And then you have mixed epidemics where you have really a fairly even mix between key populations and general populations. But you have to have a relatively high focus on both segments. Obviously, key populations are a priority because of their vulnerability and because of the importance, but some counties, there's a bigger emphasis on general populations, and that's depicted here. Next slide, please. So what we've done is we've just used some general criteria to broadly categorize the counties in Kenya into concentrated, generalizing, or mixed based on their transmission dynamics. And I think this is something that obviously we can go back and forth on. We can have some discussions about where they fit. But I think generally this helps to understand which of the counties where the biggest emphasis should be on key populations. Those are the ones at the far left, which have concentrated epidemics. In these cases, we have very high prevalence or quite high prevalence of HIV in the key populations, relatively large size of one or more of the key populations, and relatively low prevalence in the general population. We have in the middle generalizing epidemics where naturally the prevalence is high in the key populations, but this is where the general population prevalence is quite high. And the relative size of the key population isn't overwhelmingly high. And then we have mixed, where we have a relatively high prevalence in the general population, but also evidence of key population transmission at a fairly high level. And so I think it's useful to use this kind of a rubric, because at the very least, it allows you to say these are really our concentrated epidemics, and these are really our generalizing epidemics. And the other ones, you have to sort of focus a bit on both, but it gives you a little bit more latitude in terms of your focus and policies in the mixed group. Next slide, please. So if we look at this now, in these slides, what we've done is we've segmented the counties into generalizing, mixed, and concentrated by color. So you can see the red bubbles are what we would categorize more as generalizing epidemics. The yellow are the mixed, and the green are concentrated. And not surprisingly, they're categorized to a large degree by overall prevalence. But you can see that we have fairly large, if you look at this as the bubble size is proportionate to the number of new infections. It's interesting that you actually have quite a number of new infections in each of those categories. So you have some counties that are generalizing, where you have a lot of new infections, big bubble sizes. You have some mixed that have big contributions, and you also have some concentrated epidemics that are still contributing relatively high numbers of new infections. So it'll be important to ensure that the counties, particularly the ones that have a high number of new infections, get the kind of attention that they require, but also recognizing the type of epidemic that's there. Next slide, please. So this next set of slides is sort of an early attempts for us to look at program gaps. And what we've done is we've sort of expanded on concepts of what some have called an HIV prevention cascade. We like to think about this through an older public health framework, which is called effective coverage, which tries to understand where gaps are in different types of coverage. And I'll try to illustrate that as we go through these next set of slides. Next slide, please. So what we think about is if you have a focused population, in this case, we're looking at key populations. We have an estimate of the size of the population. And then what we want to do is we want to look at what is the planned coverage. The planned coverage is really what resources have been allocated for coverage of that population, and to what extent are there gaps in resource allocation or planned coverage. So as an example, if we look at female sex workers from an overall estimate of 100%, in Kenya, about the planned coverage is about 97%. So the resources have been mobilized to a large degree to cover female sex workers. The next bar, the light bar, shows what is the contact coverage. So this is to what extent have programs that are being resourced to reach sex workers, to what extent have they made any contact with sex workers. This really gives us a sense of the effectiveness overall of the programs in outreach and interaction with the key populations. And so this tells you what this set of slides and these bars really help you understand whether you've got a good program footprint. In other words, do you have enough resources? Is the resources in the right places? And then are the programs able to do the outreach to make contact? So you can see that for female sex workers, you've got some gap in contact coverage. For MSM, based on the estimated numbers, there's very good planned coverage and contact coverage. For persons who inject drugs, you can see that there's both a gap in terms of the planned coverage, but also a further gap in terms of the contact coverage. And so thinking about what the priorities would be for PWID, there would be both a need to do a little bit more resource mobilization, but also look at why programs aren't able to reach even with the resources that they have. Next slide, please. And this slide it's a little bit complicated, but all we're doing here is we're trying to look at the contact coverage in relation to the disease burden and epidemic type. So the further these bubbles are to the right, the better the contact coverage. That means, and this is just for female sex workers. So all of the bubbles at the right, you can see they actually go up to 120%. The reason for that is that there's a turnover of sex workers. So in some counties, the number of sex workers that they've contacted goes beyond the estimate. And we would anticipate that you can go beyond up to say 20% if there's a turnover of say 20% every year. So it's not uncommon for programs to go beyond. So the ones at the right tend to be having good coverage, contact coverage with for sex worker programs. But as you get to the left, you start to get counties that have relatively low contact coverage, with a few counties to the left that don't have any resources allocated for covering sex workers, even though they have concentrated epidemics where there's essentially nil in terms of contact coverage. So the priority here would be to think about the larger bubbles that have concentrated epidemics that have relatively large number of new infections. So I think this just helps us understand where the coverage is, where the number of new infections are, what type of epidemic it is, and react accordingly. And I hope it's not too busy a slide, but we can think it through subsequently. Next slide, please. Next, I'm just going to switch over to PMTCT coverage. And we went back and forth in terms of looking at how to gauge effective coverage. But we thought obviously the first place to start is looking at testing coverage. So when we look at this, out of 100 pregnant women, about 74 are being tested for HIV. And this usually is because not so much gaps in the testing program, but really more gaps in MNCH programs, women who don't go for antenatal care or don't go for formal antenatal care. So that testing gap, I think, is obviously the most important gap, because when you look at the percentage of women who have been identified as positive who are on HAART, it's about 94%. So the major gap here is not so much the sort of at the effectiveness end of the spectrum, it's really on the coverage end, the percentage of women that are being tested, which is often outside the purview of the HIV program. It's really within the purview of the MNCH program proportion who would be going for antenatal care. But this I think is something to have a deeper look at. Next slide, please. We can see that the testing coverage varies substantially by county. So the ones at the right are the counties where the percentage of pregnant women who are being tested is particularly low. And so these are the estimated number of pregnancies are the bars, and the percent that are tested is the line with the dots. And so you can see obviously there's a number of counties to the right side that have lower than you would want in terms of proportion tested. Again, this may reflect more MNCH coverage than testing per se, but it's clearly something that could be looked at. Next slide, please. And HAART coverage, again, as indicated earlier, generally among those who test positive, the percentage that are on HAART is quite high. Illustrated here again, there's not that many counties that fall below 80% of women who are positive on HAART. And so probably, and most of those are very small counties. The only county with a substantial number of pregnant women where the percent on HAART is substantially below 100% is Nairobi. You can see that it's more about 82% who are of estimated pregnant women who are on HAART. But most of the others counties at that end of the spectrum tend to be fairly small counties. Next slide, please. VMMC coverage, in this one, what we've tried to do is look at the estimated need and then the donor target and then the conducted VMMC. And you can see that there is a gap here between even the funded target and the proportion on VMMC, who've received VMMC, sorry, next slide, please. And this is focused obviously on the 12 priority counties. But here you can see substantial differences between the counties in terms of the estimated need and the target and the percentage of the target achieved. So on the left-hand side, we have the percent achieved over the target. Those are the ones that are performing better. So Migori, Kisumu, and Busia. But then as you get to the right side of the spectrum, so places like Nairobi and Nakuru, there the percent achieved over target tends to be lower. Next slide, please. And this just summarizes the VMMC target achieved in relation to disease burden and epidemic type. Most of the, or many of the counties are of the generalized epidemic type. And we can see that the ones to the right, the bubbles to the right, the counties to the right, have higher levels of VMMC target achievement. And as you get to the left, and here we see again, the major cities of Nairobi and Mombasa tend to have lower achievement in relation to their targets. Something to consider. And I mean, it's quite possible because there's a lot of flow in and out of Nairobi and Mombasa, particularly Nairobi. It's quite possible that that some of the circumcisions are being done elsewhere. But it's just something I think to explore a little bit further with respect to the VMMC program. Next slide, please. And I think one of the things that we observed is for adolescent girls and young women in 11 focus counties, out of all adolescent girls and young women, the donor target was about 15%, and the contact coverage has been about 10%. So this is the proportion of adolescent girls and young women that have been contacted within those counties through a prevention program. Next slide, please. And here we see quite a wide variety. So you have some counties at the very right that have actually reached their full target, but you have a number of other counties as you go to the left that still have fairly high incidence, but have much lower contact coverage in relation to their disease burden. Again, this is gauged by what the targets were without really reflecting on whether the targets were high enough or too low or too high, those kinds of things. Next slide, please. And then we also looked at PrEP, and what we noticed when we looked at PrEP is that it's a bit hard to read some of the, or it's a bit hard to interpret some of the ways in which the priorities are set or the targets are set. So what we did is we gathered together the general population into one big category of discordant couple. And we looked at the proportion initiated on PrEP. So if you look at it generally, overall, based on the eligible general population or discordant couples, it's about 5%, 5% of that population initiated on PrEP. Again, I think there has to be some focus on getting a tighter look at the eligibility and the prioritization. Whether this is the right 5% or whether it needs to go much beyond that, I think is something that will require further analysis. For sex workers, I would say that across the board for KPs, it's better than the general population. But again, there's a gap. Again, I think it would be important to look at what proportion is ideal for key populations in terms of PrEP. And we haven't really looked at which segment of the key populations, say, for example, young or new sex workers versus others. So I think there's some work here, but you can see that in general, the PrEP coverage is low. I think the big question is whether it's the right focus and whether it's hitting the right. Next slide, please. I'm just going to summarize the epidemic appraisal before I hand it over for qualitative, just some of the implications for programming. There's a lot more than I've listed here. Just to reiterate that focusing more prevention efforts on a subset of counties with substantial incidence would be a really efficient way to reach Kenya's prevention goals. particularly when you consider that some of these larger counties probably have an impact on counties around them, even and in the case of big cities on counties throughout the country. While certain particularly pregnant women and KPs need attention in all counties, interventions for other at-risk populations can focus on a subset of counties with selected which are selected based on epidemic typology. So I think that it would be there's a potential here to really concentrate prevention resources in a smaller set of counties, particularly where there's mixed and generalizing epidemics. Overall, the program coverage for KP programs is quite high, but there are some notable gaps both in availability and contact, especially in some counties with concentrated epidemics. And I think it would be fairly straightforward to identify those and really dig in to come up with a optimized coverage in those contexts. We're making a few assumptions here, but it appears that the main gap for PMTCT is in testing pregnant women, which we think is perhaps linked to overall gaps in antenatal care. But that would require some digging in to see whether that's whether that hypothesis is true. VMMC coverage is quite variable. I just would note that it's fairly low in Nairobi, and that's going to be that's going to remain a gap because the target there is relatively high. Adolescent girls and young women coverage is low, even in generalized and mixed epidemic counties. It generally needs scaling up, but I think even in addition to that, probably needs more attention to focus when we're talking about adolescent girls and young women. How would we focus even at the sub-county level? And then I think strategies for prioritizing and targeting PrEP coverage would really need further thinking through, especially for non-KP groups. Overall, the coverage is relatively low. So I think the question might be, where would the, how would it be best to strategically focus the PrEP coverage? And I think that could be the subject of further work and research. I'm going to stop there.